everybody, and welcome to episode 4 of Helping the Helpers Health and Wellness While Working on the Front Lines Vicarious Trauma. My name is Dr. Jafet Smith. I'm a clinical psychologist licensed to practice in the state of Florida and also in the U.S. Virgin Islands. I'm also a proud member of the T. Leroy Jefferson Medical Society. T. Leroy Jefferson Medical Society, for those that don't know, is an organization comprised of dedicated minority healthcare professionals that focus on helping the underserved populations in our community, and actively we work together to improve overall health outcomes, including mental health outcomes for community members. Today's episode will focus on vicarious trauma, which is also often referred to as secondary traumatic stress. This is something that occurs when an individual, which is often a healthcare provider, police officers, military, or other first responders, are continuously exposed to aversive details of the trauma of other individuals. Today, for this topic, we will be joined by two amazing mental health professionals, Dr. Debbie, who is also a proud T. Leroy Jefferson Medical Society member, and Dr. Mercier. I want to begin by asking you both to just introduce yourselves. So we'll start with Dr. Debbie. Can you tell us just a bit about yourself and what brought you to the field? What are some of your passions?
I'm so elated to be here. Thank you, Dr. Smith, for having us. Thank you to Be Well PBC for sponsoring us. Yes, I am a proud member of the T. Leroy Jefferson Medical Society. I've been a member for over 5 years, and it's been an honor to serve with you and other medical professionals to really promote mental health awareness to underserved communities and diverse families. So just a little bit about myself. I'm a licensed marriage and family therapist with a focus on soul care, families healing, and birthing purpose. At the Children's Services Council, I manage our Touchpoints, infant mental health, and reflective practice training initiatives. And as an adjunct professor, I teach marriage and family therapy as well as family therapy techniques at Palm Beach Atlantic University. My research is on intergenerational trauma, epigenetics, and suicide prevention. Yet I'm most proud of creating the first birth equity toolkit in family therapy to bring awareness to Black infant and maternal mental health, as well as highlighting interventions for postpartum depression.
Wow, that is a lot, Dr. Debbie. I know the community is so lucky to have you and to have you focusing on those very, different areas in T. Leroy Jefferson, and we're all lucky to have you. So thank you again for being here today, and we'll start with the questions for you. So on the extremes, we're talking about vicarious trauma. Vicarious trauma can present with various different symptoms. You have, difficulty sleeping, restlessness, racing thoughts, difficulty concentrating. Even on the more extreme ends, we have, extreme anxiety, we have sadness, and sometimes often even suicide. And I know that during the pandemic, there were different stories of medical professionals that chose death by suicide based on the different stressors that they were experiencing at the time, the different traumas, the death toll that they were being faced with. Can you tell us anything more about that?
Yes, so death by suicide is a very painful topic, but we do need to normalize the reality of it, especially its impact. As you said, today's we're 61% of physicians reported burnout symptoms in 2021, which is actually up from 40% in 2018. And so close to 7% of physicians in the US reported suicidal thoughts. So we're going to shine some light here. If we talk about suicide, we will not put the idea in anyone's head. Desire for suicide is separate from the process of capability for suicide. And so one is perceived numbness or what is known as burdensomeness. So it's this sense that your death will be worth more than your life to other people. Objectively speaking, we know that that is not true. But when people are having suicidal ideations or suicidal thoughts, wanting to take their own life, they are quite mistaken and they think that they are a burden. They truly believe in that moment that their death will be worth more than their life to others. So, those are the main drivers of suicide risk. Another behavior to be mindful of is social withdrawal, which is different from purposeful solitude or spiritual detachment or just time alone for meditation. When people have an intense feeling of loss of belonging or this idea that they don't belong, they believe that they are alienated and feel hopelessly lonely. Those are the main drivers of suicide risk. The interpersonal theory of suicide proposes that acquired capability facilitates transformation of suicidal desire or the intent, which may lead to lethal self destructive behavior. And that's when they have a plan of what they want to do and how they are choosing death by suicide. And we've seen this all too often with heartbreaking headlines of the many ways people choose death by suicide.
Yes, yes. Thank you for explaining that, especially differentiating and letting us know the difference between suicidal ideation, intent, and plan. And I also think it's very important, you mentioned at the beginning that asking somebody and inquiring about suicidal ideation doesn't mean that you're putting that in people's head. And I think that's an important thing to let people know and to educate listeners on, because oftentimes a person could be worried about a family member and they don't ask because they're afraid to put the thought into somebody's head. So I do thank you for explaining that to everybody. Now, more recently in the news, the world lost a famous TV personality to suicide, and the reports mentioned that he didn't appear to be depressed or suicidal. So, what would you say are some signs that loved ones can look out for?
Uh, Great question, and glad we're also shining a light on this because there's this idea of acquired capability because it's not an ability that we are born with. Humans are not born with this idea or ability to take their own lives. Rather, this ability to engage in suicidal behaviors is only acquired through life experiences. So these experiences could include childhood trauma, witnessing a traumatic event, suffering from a severe illness, or engaging in self harm behaviors. The more you experience, the more you begin to see that this may be something that you're capable of. Other factors, such as serious financial concerns, survivor's guilt, extreme bullying, high conflict or violent relationships. And the biggest one is easy access to a lethal means of suicide, such as a firearm. And so when people are trying to assess individual risk or even community risk, they may want to look for an individual in terms of their history of depression or other mental illness, any chronic pain, are there criminal or legal problems that they're enduring? A job loss, which also connects with financial loss, or even substance use. Looking at the person within community or systemic risk, you're going to look at, is there a lack of access to healthcare? Has there been a suicide cluster in the community? What is the stress that they're experiencing? Could it be stress of acculturation? Is there a lot of violence in the community, a lot of discrimination? These are risk factors that can lead a person to considering death by suicide. So, my heart definitely goes out to the family of Stephen Boss, as his wife and children are now survivors of suicide. And this is something in our community that we don't talk about too often. The survivors of suicide are very, very unique to each death narrative, but they can include a parent, siblings, extended family, teachers, friends, and even the clinician who has worked with the deceased. All of these people may be affected by the person who died by suicide, And it's important to note that their level of closeness may not even be a factor. So while it's subjective that those who consider themselves survivors of the deceased and what they're dealing with, those great wounds of bereavement, simultaneously, they may be trying to deal with the stigma of what happens when a person dies by suicide. A common assumption actually is that with survivors of suicide, people think that they are somehow implicitly to blame for the death. And so the survivor is often perceived to have either directly caused the person to choose it, or alternatively, maybe have done something, or could have done even something more to prevent the death. So, socially, when you think about this, it's quite a burden to bear for the family that remains, for the community that remains, for the children that remain. And so we really have to normalize mental health awareness, suicide prevention, so we can create spaces for families to grieve, for families to have privacy. So while they're grieving, they are not shamed or they're not seen as guilty. They face a lot of pain in the recovery process, and even sometimes anger and disbelief. And so I hope that the audience who listens to this podcast, especially in moments post a suicide, can recognize how important it is to listen to the family and the friends of the deceased, start or join a suicide survivors group where everyone can take time to grieve, meet with staff in small groups, not necessarily big assemblies, because we want to create spaces where this is doesn't become something that um, people misconstrue in terms of celebrating the act versus celebrating the person's life. And so, for medical professionals thinking about their organization or their private practice, really intentionally making time to meet with staff in small groups is so important, and allowing time for leave or sabbaticals. Um, Other ways that communities can come together is just to make sure they involve parents and community leaders, involve us as mental health professionals, reach out to clergy and have an opportunity for spiritual support or guidance according to their faith, if available. And then lastly, the appropriate police officials if needed.
Right. So, Dr. Debbie, you gave us a lot of great information on how to help the survivors of those who have died by suicide, the families, the children, different ways to help them process their grief. Now, should we, when should an individual seek assistance? So, if an individual is having any type of ideation, when should they reach out for help?
So I'm so happy that you asked that because we really want to strive to treat all death the same. And we know that when it comes to suicide, the gap between what we know and what we do is lethal. So we always want to lead with telling the truth and sharing developmentally correct information. We don't want to dramatize or glamorize suicide. We really want to have this intentional or authentic balance so people can be aware and, just as you were saying, take steps for their well-being. As you go back to your community and think about, what do you do with this information? You can actually create more support groups in the community, that focus on attempts of suicide, and we can shift our medical model to use the same door. Let's stop distinguishing between physical health and behavioral health. The brain is an organ that needs care, love, support, and we have to talk about what's going on in our minds. So, if a person has a broken arm, they'll get months of recovery. It is no different from a person with a broken heart or an ailment in their brain. Something else that I want everyone to consider is, what is post traumatic growth? and it's using what has happened in your life to move forward. So your adverse childhood experience doesn't have to stop your life. You can move forward, but you have to treat your whole self, your body, your mind, and your spirit. And spirituality has actually been found to be the number one factor in successful recovery. So I hope for our medical professionals who are listening, they find ways to use a biopsychosocial spiritual model to include soul care. Suicide is indeed a national crisis, but it's our time to make mental health care more accessible, more affordable, and an opportunity to act on reason as well as science. So, as we conclude today, I hope that you will have a clear plan for suicide prevention for yourself, for the clients that you serve, and your staff.
Very well said, Dr. Debbie. Thank you for that. Now, is there anything else that you'd like to share on this specific topic?
Well, I was thinking more about safety planning and social connection and how it's so important. I think we need to ensure that our medical professionals and teams actually have a team in place whose responsibility it is to conduct continuous quality improvement concerning crisis management and actually know who are those people. Sometimes a crisis happens and people feel like, "Oh, okay, I know my job, I know my role, but who am I supposed to go to? Who am I supposed to refer to?" So, I encourage everyone to review current research on best practices and crisis prevention. Join groups like the TV Roy Jefferson Medical Society, which connects medical and mental health professionals. Create opportunities for relevant practice, not just a training video or a lecture, but have hospitals and emergency rooms really allowing staff to get intensive training on suicide prevention, as well as those who may be on the front lines helping people and families daily with various mental health concerns, including suicide. So, this is just one of the best recommendations that I think reduces harm for clients struggling with suicide and clinicians who may not be skilled experts in suicide prevention, because our clients deserve clinicians who have the education and expertise level to appropriately meet their mental health needs. And clinicians equally need the appropriate training and supervision to properly serve those in need of professional care, as well as for their own personal lives. So, knowing the myths of suicide is a great way to get started. And so, Dr. Smith, guess what? We have a pop quiz for you. So, so this is just true or false. You think you can handle this? All the myths of suicide prevention?
I don't know. Let's see.
All right, let's do it. Let's go through it. So, the first one is true or false. Most people who die by suicide don't make future plans.
False.
You can tell who will die by suicide from their appearance.
Ooh, false. Yes, yes. We definitely know that there's no look.
Right, right. You have to be out of your mind to commit suicide.
Ooh, definitely a false. Another false.
If a person is suicidal, you can't stop them. They're going to do it anyway.
Well, that's a false. A lot of people that are suicidal are ambivalent.
All right, Dr. Smith, you are a 100 to 100 so far. So let's see if you can get the rest. People often die by suicide on a whim.
Ooh, false. Usually, when people are um, in a mind frame of having ideation, it tends to take a course. You know, it begins with ideation, like you talked about a little bit earlier, and then it develops into possibly a plan, and then it continues to develop into like an intent. Do they have intent? And then again, do they have the means? So it is, a course a lot of times.
Excellent, excellent. What about suicide is an act of anger? Suicide means the person was weak.
False. A lot of times people are dying by suicide because they feel like they have no options, and oftentimes they feel like it's a better decision for their family. So they feel like they're doing a service. And I think that's something that you mentioned earlier as well.
Mhm. And our last two, they're faking it. They just want to get attention. Or most people who die by suicide leave a note. Are those true or false?
Those are both false. Those are both false. Not everybody leaves a note, and it's sad, for people to even consider that a person that is expressing suicidal ideation would be faking it. Both are false.
100%. Congratulations. You've passed the pop quiz. Death by suicide varies. And it's so hard because, person by person, it's totally different. Um, but we just want people to leave with understanding. When you notice that someone has a sense of perceived burdensomeness, as well as a sense of low or no belonging, that is when we really want to support. We really want to show them their worth, their value, and how much they are cared and loved for.
So I do want to recognize your language, Dr. Debbie, that you have been using the words died by suicide and not committed suicide. So even in that shift of language, we're taking the blame off of an individual, and we're not making it seem as though they're committing a crime or an offense. We're recognizing the different difficulties that might bring a person to the decision to die by suicide, and really respecting that this is a difficulty and an illness that a person might be experiencing. So thank you for that shift in language. Thank you for the education that you have given us, and the signs and symptoms and everything that we can look out for to help one another.
You're so welcome. So glad that we're bringing this light to medical professionals as well as others in our community.
So as you know, there's many evidence-based treatments for addressing trauma, including, but not limited to, cognitive behavioral therapies, trauma-focused CBT, and also EMDR therapy. Now, Dr. Debbie, what are some of the ways that you help individuals who present in your office with difficulties that we have discussed today?
Thank you for the question. I'll try to be brief because, in our world of mental health and psychology and family therapy, there are so many amazing interventions that we could use. So I really enjoy using Dr. Douglas Fleming's relational suicide assessment approach, which focuses on assessing lethality, but not as a separate component of the clinical interview. It's a part of a overall collaborative relationship. I also use solution focused brief therapy, which is future focused, goal oriented, and focuses on solutions rather than the problems that may have brought a client to seek therapy. Also, I love narrative therapy, which is where clients get an opportunity to really remember the stories of their lives and rewrite their life. Narrative therapy really challenges dominant problematic stories or narratives that prevent people from living their best lives. If a client would like to go deeper, I use Satir systemic transformational therapy, also trauma focused cognitive behavioral therapy, EMDR, or mindfulness. I love Satir's work because it's really based on the belief that we all have four basic needs: love and belonging, self esteem and soul care, fun and play, and power and control. And so by meeting those needs, we can achieve a sense of mental health and well being.
And lastly, we're interested to know what are some things that you do to detach and recenter yourself. So I know for sure, Dr. Debbie, that self-care is very important to you. Can you share with our listeners what some of your self-care practices are?
Yes, I've been eagerly awaiting this question because self care is truly a spiritual journey to me. And I believe that we are born of just divine love to bring light into the world. And so we have to make time for what I call heart work, or inner work. And I'm actually currently studying, Dr. Smith, sometimes when we think we're done, there's so much more to learn. So I'm studying to be a spiritual director at Peacock Soul Care Institute, so I can integrate soul care in my practice for clients. And we're learning about all of these different spiritual disciplines, such as silence and solitude, wisdom, meditation, of course, but also Bible study. How do you incorporate your faith, Lectio Divina, um, prayer, fasting, and journaling? So it's truly been a really, really fascinating journey. Um, I also recently took this Wisdom Way of Knowing course by Oasis Ministries, and they described wisdom as a portal and even a technology. Wisdom as the system of knowing. And so the technology operates through meditation, centering prayer, chant, and Lectio Divina. And wisdom makes use of this ancient body of knowledge about the physiology of spiritual transformation, as well as a methodology for increasing our receptivity to a higher meaning. And so, while, we love our spa days, I find my higher self, or some people say higher vibration, in silence and solitude. Love music, meditation, and journaling. It's so powerful. So I hope that those who are listening are able to find what is meaningful to them, what brings them life, what brings them to their higher self. And I'm so grateful to share. It's really important. We have to release, we have to reset, and we have to respond to our body, our mind, and what our spirit needs.
And we too are grateful for you and that you are here and that you have shared. Thank you.
Thank you. Thank you.
All right. Dr. Mercier, thank you for being with us today. We're so thankful that we'll benefit from your perspective and expertise on this topic. Can you begin by just introducing yourself and telling our listeners a bit about yourself?
Well, thank you for the invite. I am Dr. Mercier, Jameson Mercier. I am a licensed clinical social worker and doctor of marriage and family therapy. Um, I am of Haitian descent, born and raised, and South Florida has been my second home for, wow, now almost, well, let's just say more than 30 years now. Let's just say that. Um, and so my work as a clinician focuses on, in addition to general mental health practice, but couples work, family work, what we call systems work, relationship systems. So intimate relationships, yes, but also relationships within organizations, within bigger systems, so schools, hospitals, that sort of thing.
All right. So you're the perfect person actually to talk to us today about this aspect of vicarious trauma that we'll be getting into. So now when we think of responses that healthcare providers and healthcare professionals might have to the repeated exposure of trauma of their patients, we often think of what their individual experiences might be. So we think of them having difficulty concentrating, experiencing racing thoughts, sleep disturbances, maybe disruption in their level of energy. But vicarious trauma can also, as you know, shift like your worldview and your perspective and your belief systems. And I'm sure, that affects relationships. So what are some of the ways that stress and vicarious trauma show up in relationships in your experience?
So the first thing I say when we're talking about how anything might show up, so in this case, we're talking about stress and vicarious trauma, it is unique to everyone. So there are some general things you look out for, but understand that they don't show up the same in everyone. So someone who is an introvert, that isn't necessarily a sign that they might be dealing with some stress or some trauma, but there are levels. Okay, and so if this individual uh, might seem a bit more isolated, a little bit more reserved, and not compared to the spectrum of reserved people, but for him or her. Um, or their responses to their partner within their relationships, they may be known to have a slick mouth, let's say. They may be short, to have a bit of a temper, but it's hitting a little differently. Um, those can be signs within the context of a relationship that something is going on. Um, as practitioners, providers, we see things that we don't necessarily want to take home with us. Some practitioners find it impossible to hold those things. So there's this need to divulge. Um, in extreme cases, it might be almost I hate to use the word manic, but just nonstop, like they just need to purge. So that may be a sign. Um, and we're talking about extremes, of course, either being extremely isolated or just need to talk. But the key is to know the differences for the person, the individual themselves.
Yes, yes, I hear you. So everything, so you're knowing of an individual, you'd be able to kind of differentiate what is different for that person. So what seems off for that person.
Correct. Looking at behavior, looking at functioning, you know, they perhaps, are eating much less, sleeping much less. Those are standard responses that you might see, but relationship wise, it really stems on interaction, interpersonal engagement or lack of engagement if we're focusing purely on relationships.
So my next question would be then, how can healthcare providers maintain healthy relationships despite their stressors? So how can they make their relationships flourish even with the amounts of stress that they have?
Making your relationship flourish. Ideally, that's what we want. Um, in my work with couples, I've learned that sometimes we just want to maintain. Let's not discount maintaining the relationship, especially if we're talking about high stress, really being in a position where it's very demanding. Um, we do take stress out on the people that are in our lives, whether that's a spouse, a partner, our families. Um, and we first, help them thrive and flourish by not starving our relationships of what's needed. So what's that? We're talking conversation, we're talking about engagement. If you're in a marriage, um, whatever date night routine, dinner with the family perhaps, um, those things help to sustain the relationship. Um, we In relationships, you often hear that people will say they have a communication problem. Um, I feel sorry for communication because everyone blames communication for the issues. Um, but if someone's talking less, okay, they're communicating less, but that can also be indicative of something much deeper. And sometimes we can get at that, sometimes we can't, and yeah, maybe we leave that for another time. But relationship routines are important because as we break away from those routines, um, it gets harder and harder to maintain where that relationship once was. And seeing that relationship as a support, that begins to go away actually. Now that becomes possibly one more stressor in addition to everything else.
So part of what I heard you saying was, so for the partner of maybe a healthcare professional, what they can do maybe if they notice their partner pulling back or changing their communication style, instead of allowing it maybe to become a disruptor, they can maybe inquire about what the change is.
Absolutely. And again, this is some partners are much more comfortable being a disruptor, right? Because as much as we, as clinicians, doctors, therapists, we want to help, we have our flaws too. We're not always receptive to people wanting to help us. But as the partner, yes, if as much as you're able, if you can interject and disrupt um, these unhealthy habits and patterns that you see developing, it can help. There's no guarantee that you may not get any blowback. Um, just be warned, but those things, it does help.
Okay, all right. What recommendations would you give to a person who's attempting to reconnect socially? So I know you said that different people cope different ways. A person, just because they're spending more time alone, doesn't mean that there's something negative going on with them. But what if this is a person that used to be social, they're withdrawing? What recommendations would you give to a person? They're attempting to reconnect socially. They want to combat loneliness.
I would say start slow. Start slow. When we engage in self-care, essentially we're talking about self-care. Um, there's there can be a lot of pressure associated with self-care, and if we're not careful, now the practice or practices we implement for self-care now become sources of stress. And then you feel like it doesn't work, or we need even more self-care. And so it can be a vicious cycle. So I encourage people to start slow. Um, it does help to if you notice or you notice your partner is isolating or detached, it does help to encourage things to kind of break them out of that. Um, do we want to take them to Disney World? Well, let's maybe not right away, right? Let's start with a walk, maybe, right? Let's go. We can step it up. We don't have to jump to a big trip or let's go have a family reunion. I don't think they want to be seen in that state, especially if they're not communicating with you about it. Chances are they don't want family and friends to see that. But we can go for walks. We can um, engage in small activities and, outside the beach. And I'm saying these things, but whatever makes more sense to you. You may live somewhere where the woods, get out there. Sun, get some sun. Um, but you don't want to do too much too fast, because inevitably too much too quickly leads to failure. And when people are in a position where they're already withdrawing, dealing with stress, and it only takes one defeat to feel like, oh, nothing's going to work. And as clinicians, we're not immune to that feeling. So I definitely say, if nothing else, start slow, small steps.
Yes, that definitely makes sense. Question in terms of treatment. So, Dr. Mercier, is there anything that you do specifically when working with individuals or couples who are experiencing a disruption in their relationship?
Specifically, it comes down to strategies and coping skills. Um, I like to see my work as you actually use the term being a disruptor. In some ways, I see myself as disrupting the line of thinking that exists. Um, I would like to say specifically, I have people do, these 7 things, and then we're great. Um, but it doesn't often work out that way. Uh, but they do stem from, so let's look at what's happening and what have you tried that perhaps didn't work and how can we tweak it? Because back to what I said a moment ago, it isn't that we need to make massive changes. Um, if you ever tried any golf, or if any of your listeners play golf, the adjustments you make in golf are not big adjustments. They are very, very tiny adjustments that lead to these great um, um, changes in your golf game. So similarly, um, it does involve looking at what's going on. And clinicians and providers can be a little tricky in that the knowledge exists. We often, and we hear this, when we know better, we do better.
Not
Um,
always. Not always
it's
that easy.
not,
Yeah.
no, it's not. No. And so let's first figure out, is this a uh, lack of skill or is it a lack of will? And so once we know that, then we know which route we're going to take. Um, like I said a moment ago about communication, if you assume a lot of the issues in relationships are based on communication, you miss a lot. Um, a lot of communication problems stem from trauma that we're not communicating, don't know how to communicate about. And so, no matter what communicating skills you try and you learn, until you get at the trauma, you don't even have an opportunity to use it. So there's a lot of detective work that goes
Yeah.
into figuring out what exactly we're dealing with here.
Yes, yes. So no easy answer. And like you said before, everybody's different. So it really is an individualized approach. So in terms of your own self-care, because you are a clinician, so you, like you said, we're not immune to any of this, right? Because we are being faced with um, the difficult things that people experience in their lives. They come to us and they speak about it. Physicians, our first responders, they are responding to people oftentimes at the most difficult times of their life. So what are some things just in terms of self-care? What do you do for yourself? What are your personal self-care practices?
So my self-care practices have grown over the years. And I say grow, I seem to just keep collecting them. Um, and that's, if that's what I need, that's what I need.
You have a
I
toolkit
have,
now.
well, it's more like a garage.
Beautiful.
Um, there was a time when I did, yeah, a toolkit worked. But clinicians lead lives and they have families, children, and they get promotions perhaps, and they start practices. And, uh, for example, where you once needed a screwdriver, now you might need a drill, you know? And so I see that that's what's been happening for me. I take regular walks. That's a practice that I think I'll always have, just being outside. Daily walks. I take walks twice a day, just for me, but I also have a dog. So he's part of uh, my self-care. Um, I've discovered um, I discovered a love for outdoors years ago, and so I regularly go on hikes, um, camping, sleeping on trails, um, 3, 4, 5 days at a time. Um, I enjoy music. Um, there are times where listening to music helps, and then there are times where I need to play music. So I play an instrument and I play regularly at, with some people. I play in a band. So there's community there. Um, and some things I don't do, there's just certain shows and movies I don't watch. Um, uh, whether they're reality or drama shows. Um, mainly because I feel like I get enough drama from my clients, and so
Mm-hmm.
there's no escape for me if I'm treating clients and families and then I binge a show on Netflix for the whole weekend. There's no separation. Um, and so I protect myself that way. You'll often hear people talk about work-life balance. And that again is something that's different for everyone. Um, COVID has really kind of caused us to take a look and figure out what priority is, not priorities, right? If you have more than one priority, then, right, by definition, there ought to be one. And so I encourage people to look at that, which is not always easy. I get it. But for me, um, I put things in place that work for me, that I can stick to, that don't discourage me, and then as well as connecting with other my community of clinicians. There are times where I need to check in with a clinician. There's no shame or fear in having to process anything that you may be going through, experiencing. Um, Call it consulting, if you will. Um, I personally,
Yeah,
I do what I need to do to stay well. Some days I need more.
absolutely.
Some
You have a number of different things.
I think because of the demands placed on me, um, I think it just makes sense for me. Um, just having redundancies. If I call Johnny, he's not available, I'm gonna call Bob. And if Bob's not there, I'll call Susan. If I can't go for a walk, well, let's play some music. So y- I know for me, I need to have enough in place. If I can't get to a hike this weekend, all right, let's go out to the park with the dog and just toss the ball around. Whatever works for me.
Yes. Well, you have given our listeners a lot of different options, so that they might be able to look into to see if they can incorporate into their own self-care routines.
Yeah, yeah. Let me also add, um, and I'm not pointing any fingers. There, you hear about social media, and some people will turn to social media to escape, and we all need to escape every now and then. Um, and social media is full of wonderful content. There are lots of people doing great things on social media, but we also need to uh, be intentional about what we're consuming on social media as well. Um, and when, and being aware of what our mental states are, because whether you believe it, accept it or not, you are more vulnerable to certain things depending on what's happening for you, um, especially when we're stressed. When we're stressed, we are definitely more susceptible to different influences. And so, I'm not in the business of policing adults, but just check yourselves and just how much social media you're consuming, because there is a whole other world out there.
Yes, yes, absolutely. Well, I want to thank you one more time for being with us here today, for sharing your expertise and your knowledge with our listeners, and for giving everybody a lot of different options in terms of what they can do for their own self care, just different ways that they can help maintain their relationships despite the stressors of, of the job. Thank you again.
Well, my pleasure. It's been great talking with you, and I hope what I've said today is useful to your listeners.
More information related to secondary traumatic stress and compassion fatigue, please visit our episode 3, Admitting That You Are Not Okay. Once again, we want to thank our listeners I want to mention that if you or someone you know is struggling with thoughts of suicide or self-harm, please reach out to the National Suicide and Crisis Lifeline by dialing 988. Once again, this podcast was brought to you by T. Leroy Jefferson Medical Society. We thank Be Well PBC for sponsoring this podcast and allowing us the opportunity to further the mission of T. Leroy Jefferson Medical Society and to bring this information to all of you listeners. Thank you.